If you'd like a copy of this lecture, feel free to email me at opcal@aol.com or knowledgepluspro@gmail.com. My background is in neurodiagnostics globally. I'm registered in EEG and evoked potentials, epilepsy, and intraoperative neuromonitoring. I'm a fellow of the ASNM and a fellow of ASSET. I'm currently on the board of the ASNM. I was previously on the board of ASSET and CSET, and I love having fun, and I hope you enjoy this lecture. I have nothing to disclose. I have no financial relationship with any capital equipment or disposable supply vendor outside of education. The graphics in this presentation consist of stock photography. All EEG examples are de-identified. Good afternoon. And in neurodiagnostics globally, I'm registered in EEG and evoked potentials, epilepsy, and intraoperative neuromonitoring. I'm a fellow of the ASNM and a fellow of ASSET. I'm currently on the board of the ASNM. I was previously on the board of ASSET and CSET, and I love having fun, and I hope you enjoy this lecture. I have nothing to disclose. I have no financial relationship with any capital equipment or disposable supply vendor outside of education. The graphics in this presentation consist of stock photography. All EEG examples are de-identified. First, we're going to look at case studies comparing seizure versus sleep disorder, seizures versus epilepsy, nocturnal seizures, and then we're going to return to the case studies and get a final ruling on is it seizure or is it sleep disorder. What's really interesting to me when I'm lecturing to epileptologists and I give these case studies, they all have the same answer to all three of these case studies. They say epilepsy. However, if I'm lecturing to sleep techs, they all think it's a sleep disorder. So case studies, seizure versus sleep disorder. Our first patient is a 4-year-old Asian male. He was full-term vaginal birth with APGARs of 1 at 1 minute and 2 at 5 minutes, which just means after 5 minutes, he was active. He had normal heart rate. He was reactive to stimulation. So normal birth, nothing notary about his birth. Now, one thing that is a flag in the EEG world is Asian, because they do have a higher propensity to seizure. So again, that might be why epileptologists are kind of leaning toward that diagnosis. So he had normal development with simple words, sentences by 18 months to include mama, dada, water. So he had no developmental delay at 18 months. After 18 months, speech development ceased, so he became nonverbal, not really nonverbal. He could say words like la, 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 but he couldn't interact in a meaningful way. And he, of course, speech regression. He was able to follow commands. So if mom said, eat your milk, do this, he was fine with that, but he couldn't express himself. He had a routine EEG at 18 months. It was normal for age. His diagnosis was autism. He was being seen in the sleep lab for recent onset of periodic nightly arousals associated with brief scream followed by a cry. Mom reports that Thomas, post-episode, would appear sweaty, had a glazed look, his bedclothes, sheets, and blankets appear disheveled. His BMI is normal. His social history, parents were divorcing, and mom reports increased behavioral issues. So Thomas, interestingly, again, he's 4 at the time of arrival in the sleep lab. He's hypergraphic and hyperlexic. So this little toy he carried around with him all the time. And in this toy, he would write on this toy to communicate. So if he said, I want a cookie, he'd write that out. Now, at age 4, he had a relatively extravagant vocabulary and ability to write. So his intellect was there, but not able to speak. Again, maybe consistent with autism. The patient is toilet trained and has no nocturnal enuresis. Thomas was also currently diagnosed with sensory integration disorder. Again, everything pointing to autism. He had frequent self-stimulation involving bilateral twirling of his hands. And then he had not meaningful speech, but he would say things like la, 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 la. When I went to pick him up in registration, he was literally spinning around, moving, twirling his hands, saying la, la, la. A sleep study was ordered. What is the provisional diagnosis? Is this a nocturnal seizure or is it a sleep disorder? The second patient is Roger, also a patient of mine. He was 48 at the time we saw him in EEG. He presents to the emergency department after a motor vehicle accident. So he was ordering fast food at a drive-up window at the time the episode occurred. So he comes to the window, he orders his food, and then the patient was found. The clerk wants to hand him his food, but he had somehow left the parking lot, gone up a grass embankment, had crossed 3 lanes of highway, as you see here. Then he went over the grass median, then 3 more lanes of highway. And then luckily he ended up on the other side, but there was a little hill there and it stopped his car. So he had crossed 6 lanes of highway and the car was discovered stopped on the roadside and he was found at the scene disoriented. His body mass index was 40. He had 6-year history of diabetes managed with medication, metformin. He had a 4-year history of depression, but no medication. The patient reports he does not snore. The spouse reports the husband does snore and sometimes snorts arousal. He also makes a key noise and wakes himself up. What is the provisional diagnosis? Our last patient is a 21-year-old female with diagnosis 1 year ago with restless leg syndrome. The patient started on a homeopathic daily supplement, which she reports has slightly improved her symptoms. The symptoms increase when relaxed or when sleeping. She's currently seeking consult after her boyfriend reports periodic episodes where he is awakened in the night due to an increased kicking, that very forceful, and she's had 5 episodes over the last 4 months. The episodes are brief and without arousal. So she wakes her boyfriend up, but she herself continues sleeping. What is the provisional with Helen? Helen's 21, by the way. So let's first talk a little bit. We're going to return to these case studies. Let's talk a little bit about the difference between seizures and epilepsy. They're not synonymous. They're not synonymous at all. All patients with epilepsy have or have had a seizure. Not all patients with seizure have epilepsy. You can have a seizure and not have an epilepsy diagnosis. So seizure can be related to some outside factor like fever, like toxic exposure to something. Epilepsy, and they won't be diagnosed just because they had a seizure, just because their EEG is abnormal. They won't be diagnosed with epilepsy at this point. Once the underlying cause goes away, the fever, the tumor, the stroke, once that stops being a factor, they're not considered to be an epileptic. Now, let's take the case of a baby who has 7 febrile seizures during the time they're having their fever. Once the fever is over, they're not considered epileptic, even though they had 7 events. The number of events is not relative. However, after that fever, if they have 2 or more seizures separated by 24 hours or more with no fever, no tumor, no cyst, no underlying cause, now they are considered to have epilepsy. The electrographic seizure sign is spikes in the EEG. Now, with spikes in the EEG, they always say we don't treat the EEG, we treat the patient globally. However, if you ask any epileptologist, if a patient has spikes in their EEG, even without underlying cause, we don't necessarily treat it if their clinical profile isn't representative of seizure. However, this patient should not drive because the propensity to have a seizure is very high. Again, we do not treat the EEG, we treat the patient. At one point, I was doing training and we had an 18-year-old patient volunteer for a conference, and his job was driving around job sites in housing construction. And he was asymptomatic. He was a volunteer. And when we hooked him up, no comorbidities, very healthy 18-year-old guy. And at conference, we're recording the EEG, and he had generalized spike and wave. So the question here is, do you medicate that without any clinical signs, or do you ignore it? So after we were finished with the EEG, we woke him up and asked him, do you have any dizziness, syncope, anything like that? And he said, you know what? Sometimes I feel spaced out and I feel a little weird. So we called neurology to come in and visit him. And the decision was made because if he did have a seizure, he would lose his job. So it was decided to medicate proactively. We're going to talk about the seizure classifications. So there are different categories of seizure. These categories were defined by the International League Against Epilepsy. And by the way, this website is probably the most informative website regarding epilepsy. So a couple of years ago, we defined 2 categories essentially. Partial seizures, which are divided into 2 categories, simple partial and complex partial, and then generalized seizures. Now, status epilepticus is when a patient goes into persistent seizure, and those patients are typically in the ED, in the emergency department. In 2017, they changed the seizure classifications from partial to focal, and then generalized seizures and unknown. Seizure semiology in focal seizures consists of, in the patient, they'll have focal signs, like just their arm on one side, just their face on one side, just their legs on one side. Now, on the EEG, it will correlate with that manifestation. So there'll be spikes or polyspikes over the area of the brain that's responsible for controlling that part of the body. Now, with generalized seizures, they have more classically what lay people think of as a seizure. Their entire body is moving, and they have spike and wave over the entire EEG. Which is more common, focal seizures or generalized seizures? So is it happening in one part of the brain, or is it happening in every part of the brain? Temporal lobe epilepsy accounts for 60% of patients with epilepsy. And so temporal lobe epilepsy is more common than generalized. Temporal lobe epilepsy is the most common type of nocturnal seizure. So this is the homunculus And I just want to point out, this is on the left side, the motor strip, on the right side, the sensory strip. This would be the top of the head, as you see in this picture up here. So temporal lobe epilepsy, and specifically left temporal lobe, is the most common. But if that's where the focus is that if that's where the spikes are, you can see that's the representation of the face. So they're going to have eye deviation, head deviation, lip smacking, lip licking. Now, typically, patients and parents are very poor reporters of manifestation, especially nocturnally. Unless they sleep with the child, they're not going to be aware of what's happening during the event. Now, over C3 and C4, that's your hand and arm. So when you have epileptiform discharges there, they'll have hand and arm movement contralateral to the side of the focus. So this kind of represents looking at a bird's eye view of the International 1020 system. This represents the anatomic localization for these electrodes. So again, T3 is face, anything with the face, eye deviation, lip smacking, lip licking, and then over C3 and C4, that's hand and arm movement. CZ would be feet, and then visual hallucinations come from the occipital part of the brain. Again, we wouldn't be aware of that in nocturnal seizures because, again, no one's there to see it. So nocturnal seizures, the terms ictal EEG and interictal EEG describe ictal EEG is the EEG during the seizure. Interictal EEG is the EEG between seizures. Most AEDs, anti-epileptic drugs, do not suppress the interictal EEG abnormalities. So although their clinical seizures go away, they still have spikes in their record. And this sounds like a bad thing, but it's really our gold, because if they have not had a seizure, let's say for 1 year, 2 years, and they want to come off their medication, we can do an EEG. And if we do not have interictal spikes, it's safe to take them off their meds. If, however, they still, even though they're seizure-free, if they have interictal spikes, it's not safe to take them off their meds. So EEG is the tool we use to define whether they are truly epilepsy-free. So optimizing the recording. What if I were to lower the high frequency filter to 3 hertz in the respiratory channel? What if I were? You all know that that would really cut out the presence of the respirations. So in EEG, they recommend exactly a 35 hertz high filter. So the high filter recommendation when we're trying to rule out epilepsy versus seizure is a 70 hertz high filter. Spikes have a duration of 20 to 70 millisecond duration. Now, that means the spike frequency is 14 to 50 hertz. So if you're using a high filter of 35, you won't see the spikes that are potentially present. Now, problem with missing an epilepsy diagnosis is epilepsy is not, it's treatable, it's not curable. So when you limit those filters, what's going to happen is they're eventually going to come back. But the longer we wait to medicate, the harder it is to actually control the seizure. So the high filter setting of 35 on the EEG channels would attenuate or remove spikes from the record. So optimizing recording. It's recommended that you do an extended montage. And over on the right here, we have a chart about the tendency of seizures to occur in sleep. So you see here that we have distribution both in and we want to focus on the red, sleep category, we have representation frontally, temporally, and posteriorly. Most often frontally. And again, here's a blow up of that screen. So baby blue is awake, red is asleep. So we have to have electrode coverage over all of these areas. The montage of choice is called the double banana. Now, the reason it's called the double banana is if you draw the picture of the montage out, it looks like two bananas. Everybody asks that question. Optimizing the recording. This is an example of the double banana montage, including extensive frontal, temporal, and occipital recording. Now, I want you to notice something down here in channel 17 and 18. I've added the C3 to CZ and CZ to C4 channel just so we can get a picture of what's happening during sleep. Are they sleeping? Frontal lobe seizures more commonly begin during sleep. Temporal lobe seizures more commonly during wake and drowsiness. And with frontal lobe seizures, deep in sleep, temporal lobe seizures, it's really right when they first become drowsy. Temporal and occipital seizures generalize more during sleep. Frontal lobe seizures less commonly generalize. Focal seizures are rare in REM sleep. In fact, the truth is we rarely see REM sleep seizures. In what stage of sleep do seizures happen? So here we want to focus first on the red or orange. Most of those seizures occur in drowsiness and very light sleep. And looking at the baby blue, again, predominance in stage 2, rarely in REM. When we look at the comparison between sleep disorders and epilepsy, we have to look at the timing. So non-REM parasomnias happen in the first third of the night. REM behavior disorders, later 2/3 of the night. Nocturnal seizures can happen anytime. Again, most commonly during the first 2 hours and last 2 hours of sleep. And psychogenic events, psychogenic means they don't have epilepsy, but they have some propensity to mock or fake a seizure. They can happen anytime. Memory of the event, non-REM parasomnias, usually none. REM behavior disorders, they'll have dream recall. Nocturnal seizures, you really rarely do they remember. And they usually come to consciousness or wake up and they don't remember that they had an event. Psychogenic events, they have no memory of it. Stereotypical movements, the only one that has stereotypical movements are nocturnal seizures. PSG findings, non-REM, arousal from delta sleep, REM behavior disorder, EMG tone during REM sleep, nocturnal seizures, potentially epileptic activity, and psychogenic events occur from waking state. So this last category, they really don't present with nocturnal events. Frontal lobe seizures versus non-REM parasomnias. Now let's focus. Remember we talked about Thomas. Thomas was 4 years old. In frontal lobe seizures, the average age of onset is between about 11.8 age. Non-REM parasomnias are less than 10 years old. So with Thomas, we're kind of leaning toward something. He's 4 years old, probably not frontal lobe seizures. Attacks per month with frontal lobe seizures is 20 to 40. So very high incidence. Non-REM parasomnias, 1 to 4. So very low frequency. Now, Thomas was having frequent events in the night. With frontal lobe seizures, untreated, we typically see increased frequency. With non-REM parasomnias, decreased or disappearing. Movement, semiology, what is the patient doing? In frontal lobe seizures, it's stereotypic. In non-REM, it's polymorphic. Attack onset with frontal lobe seizures can be any time during the night. We looked at that already. With non-REM parasomnias, it's the first third of the night. Attack distribution for frontal lobe seizures, it is non-REM, stage 2 or N2, non-REM sleep. With non-REM parasomnias, it's 3 to 4 non-REM. Motor pattern, of course, they have repetitive types of attacks. With non-REM, absence of motor pattern. The duration of the attacks, and let's look at this because this is a big issue, less than 1 minute, where non-REM parasomnias last several minutes. So with Thomas, he doesn't really fall into the category for age-wise, for onset, because his onset was at 4 years of age. So he had the speech arrest linked to an autism diagnosis at age 18 months. And then he started having his events at age 4 years. Now, diagnostic evaluation, we always start with a case study video. And if that doesn't yield anything, we would do a sleep deprivation where we have them stay up till 3 in the morning, and then we do them first thing in the morning. So about 3 hours of sleep, and I think is the yield to 52%. Now, if that's also normal, then we have to get a 24-hour EEG both in natural sleep, and that has high yield, 87% than normal if they have epilepsy. Nocturnal seizures occur in 60% of children with epilepsy, many of whom have seizures limited to sleep. Most nocturnal seizures arise from N2. Again, very early in the night. And again, REM onset is rare. Of course, there's a link between sleep apnea and seizures. Apnea is associated with a higher seizure rate. Almost a third of the patients with intractable epilepsy have evidence of sleep apnea. Apnea treatment decreases seizure frequency. Now, also, anti-epileptic drugs induce weight gain. EEGs are frequently sedating, increasing the incidence of apnea. So epilepsy associated with sleep, generalized epilepsy, can induce sleep random, which everyone's familiar with, and also juvenile myoclonic epilepsy. So sleep is really important in a JM patient. Now, juvenile myoclonic epilepsy, those patients have seizures usually within an hour or an hour and a half of waking up, and they just jerk like really quick. So looks like seizure is seizure. Focal epilepsy is so limited to central temporal spikes, occipital epilepsy of childhood, frontal lobe epilepsy, and Landau-Kleffner. Now we're going to come back to Landau-Kleffner because that's important to the case studies that we looked at. So let's return to the case studies. Is it a seizure or is it a sleep disorder? So here's our Thomas, 4-year-old autistic, nonverbal male. At the time we did his EEG, an EEG was not ordered. We had sought volunteers for cognitive functional delay in children specifically in our lab. So when Thomas came to me, an EEG was not ordered. A sleep study was not ordered. So we're talking now at age 18, he had an EEG. And when he came to us, it was not ordered until he had the sleep disturbance. Now, when we hooked him up, this is what we saw in the EEG. And after he fell asleep. Now, at the time that he was brought to us, he was parents were planning on putting him in a special ed classroom. So at age 4, this hyperlexic, hypergraphic, He could read and write at age 4 and had a very proficient vocabulary. He was going into special ed at age 5 when he entered his first year of school. And as soon as we saw this EEG, after he had fallen asleep, it was determined that we should immediately page neurology. Now, the good news with this little boy is he entered regular kindergarten, which is the first year of school. He entered regular kindergarten at age 6. Now, the diagnosis is Landau-Kleffner syndrome, also called benign epileptic aphasia. So what we were looking at, and this pattern is called electrical status epilepticus in slow wave sleeps. So with Thomas, although he had nocturnal events, it was not a sleep disorder, it was epilepsy. Our second patient we talked about was Roger. He's the one that went across the traffic lines, age 48. He was a 48-year-old obese male, history of snoring, who had the auto accident. And by the way, he was fine. When we hooked him up, he had generalized spike and wave in his record. So again, Roger had epilepsy and not sleep apnea and not excessive daytime somnolence. Now, the funny ending to Roger's story is he had gone back to the restaurant. He had paid for his food, but he never got his food because he had hit the brakes and had gone across traffic. The funny thing is he went back to that restaurant and the manager and some workmen were fixing all of the grass in front of the restaurant that Roger had burned through when he hit the gas. And Roger goes up to the manager and he says, "Well, what are you doing?" And he goes, "Oh, a guy had a bad car accident here and we have to resod the whole front lawn." And Roger goes, "You know what? That was me." And the manager goes, "Oh, I'm really sorry. I hope you're fine." And Roger said, "I paid for my food, but I never got it." So they gave him the food. Now let's go to Helen, age 21, with restless leg syndrome, diagnosed with restless leg syndrome. And her EEG during sleep was normal. So we want to focus here on the C3CZ, CZ-C4, and she has not only normal V waves, she has lateral eye movement. That's what we're seeing up here in the frontals. So her EEG was normal. So with Helen, not seizure. And again, I'm blowing this up a little bit so we can focus here on right in the middle of the screen, the phase reversal at the vertex. Normal. Thank you so much for joining me today. Have a great time in Vietnam.